I am Dr. Jaiswal, Professor in Surgery and Medical Director. We'll be talking about the liver. This is a collection of multiple small topics which could come as short notes or as part of a long answer question. So we'll try and cover them in the next 1 hour. So like I said, a typical long question could be describe the surgical anatomy of the liver and discuss the management of liver abscess. So that will be part of a question, or a short note on liver imaging, child Turcotte-Pugh scoring, MELD score. So we'll try and cover all these small topics in the next 1 hour. So to start, the word liver has its origin from a Greek word hepar, which means repairable. Now what you see here is the picture of a person called Prometheus. This is from Greek mythology. So Prometheus gave the gift of fire to the human beings, as a result of which his king got very annoyed. So Prometheus was tied to a mountain, and the king used to send his eagle every day to feed on the liver of Prometheus. Now, much to his surprise, whatever the eagle ate during the day would regenerate. So that is the importance of liver tissue. It is capable of regeneration, and this is a fact that we use when we treat liver tumors or we have patients donating a portion of the liver. So the liver which is donated or resected during a surgical operation would regenerate. So that is the importance of knowing the context of mythology as it is being used today in modern day practice. So starting with the surgical anatomy, the first part of the lecture. The liver is derived embryologically from the primitive foregut. It's the largest organ in the body. Weighs approximately 1.5 kilograms. What is the extent of the foregut? From where does the foregut extend? Up to which point? Second part of duodenum, right? So say up to the second part of duodenum. So what are the other structures derived from the foregut? The esophagus, the stomach, the first and second part of duodenum, the liver, the spleen, the gallbladder. So liver is one of the structures derived from the embryological foregut, weighs about 1.5 kilograms. It's located in the right upper quadrant and it is protected by the rib cage. Reddish brown in color, and it is enclosed in a thin sheet which is the Glissen's capsule. So the Glissen's capsule is pain sensitive, and stretching of the capsule results in pain, as is seen in inflammation and other infective disorders. Now the next thing is the liver is supported by multiple ligaments, and these are the falciform ligament, which is what you see here. It anchors the liver to the anterior abdominal wall, and you have the round ligament here, which is the remnant of the umbilical vein which enters the lower end of the falciform ligament. Then we have the two triangular ligaments, the right and the left, which anchor the liver to the diaphragm, and they extend anteriorly on the liver as coronary ligaments. The applied anatomy for these is that firstly they keep the liver suspended, and secondly, when one is operating on the liver, one has to divide these ligaments in order to approach the liver to bring it down so that we can operate on it. There is one more applied anatomical aspect here. Normally these ligaments are avascular. They can be divided without any bleeding. But when one develops portal hypertension, these become the sites where collaterals develop and they may become vascular. So some more ligaments. The gastrohepatic ligament. Now this is important. So this is the liver, this is the stomach, the lesser curvature and the duodenum here. So this is the gastrohepatic ligament. Normally it is very thin, also known as the lesser omentum. The free edge here contains three important structures: the hepatic artery, the portal vein and the common bile duct. So this is the hepatoduodenal ligament, which is the free edge of the gastrohepatic ligament, and it contains these three important structures. The applied anatomy is that this is the place where the foramen of Winslow is situated. The foramen of Winslow, or the epiploid foramen, is the place where the peritoneal cavity communicates with the lesser sac. So one can insert a finger in this, and if there is severe bleeding, or one has to stop the bleeding in cases of trauma or during liver resection, one can put a finger there and apply what is known as a vascular clamp. So if you clamp all these three structures here, the bleeding can be temporarily controlled and one can perform the surgery over the liver. So this is the applied aspect of the anatomy. Next we come to the blood supply. The liver is a richly perfused organ and receives about 1.5 liters of blood per minute. This blood comes from two sources, the portal vein and the hepatic artery. So the major portion is through the portal vein, 75%, and the remaining from the hepatic artery. The common hepatic artery arises from the celiac trunk, divides into the gastroduodenal artery and the hepatic artery proper, which then runs into the hepatoduodenal ligament, which you saw on the last slide. Near the hilum, this divides into the right and the left branch, which supply the right and left lobes of the liver. As surgeons, now this is what is the ideal anatomy, but the variations are seen in almost a quarter of these patients. So one has to be very careful when one is operating in this area. So the next is portal vein, which supplies about 75% of blood to the liver. It is formed by the confluence of the splenic vein with the superior mesenteric vein. Where does this confluence occur? Posterior to the pancreas, and the inferior mesenteric vein normally joins the splenic vein. So the portal vein is formed by the confluence between the splenic vein and the superior mesenteric vein. Once again, this goes through the hepatoduodenal ligament and has two divisions, the right and the left one. This is a valveless vein. There are no valves in it. That is why it's called the portal vein. And the normal pressure in this system is about 3 to 5 millimeters of mercury. Here also about 1/3 of the patients show variation from the normal portal venous anatomy. Okay. So this was the blood supply. Now the venous drainage. So there are three veins, the left, the middle and the right hepatic vein. These drain into the inferior vena cava, in the suprahepatic portion of the inferior vena cava. The left and middle hepatic veins usually join each other to form a common channel before they empty into the IVC. And the right hepatic vein inserts separately. Okay, so three veins, right, middle and left. Left and middle usually join to form a common channel. The right one drains separately into the inferior vena cava, and from there it goes into the right atrium. Right. So what you saw on the gross morphology, there is a falciform ligament which kind of broadly divides the liver into the left and right parts. But the functional division or the segmental anatomy of the liver is through the cantilized line which passes through the gallbladder fossa and the IVC. Is there a problem? We will come and mark it for you. Excuse me, this can be done after the class. And if you want to leave, you're most welcome. So the cantilized line passes through the gallbladder fossa and the IVC. This divides the liver into the functional right and left lobes. There are 8 lobes, 4 in the left, 4 in the right, and each segment is a distinct functional unit with a branch of the hepatic artery, the portal vein, and draining into a bile duct. The importance of knowing this is, once we do a liver resection or a person donates a portion of the liver, these segments are removed and they are then transplanted into the recipient. So 8 segments. These are described by Quino. This I am sure you must have read in your first MBBS. And the left lobe comprises of segments 2, 3 and 4, and the right is 5, 6, 7 and 8. In a normal person with a healthy liver, almost 75 to 80% of the liver can be resected. So how many segments would that be? There are 8 segments, so 75 to 80%. One can almost resect up to 6 segments if the liver is otherwise healthy, and still hope that the person will have a normal survival because the liver would regenerate like we saw earlier. So this is the importance of knowing the segmental anatomy. So before we go on to the physiology, can we just summarize the relevant surgical anatomy of the liver? If there is a short note or a question, what all would you write? Start off with the origin, derived from the foregut, weighs about 1.5 kilograms, supported by various ligaments, falciform ligament, triangular ligament, round ligament. You have the gastrohepatic ligament, okay. The free edge of the gastrohepatic is the hepatoduodenal ligament, which contains the 3 vital structures: hepatic artery, portal vein and the common bile duct. The applied anatomy of knowing this we have already discussed. In case of severe bleeding, one can apply a clamp here or even pinch it with a finger to have temporary control over the bleeding while the bleeder can be tackled. Then we came to the blood supply and the venous drainage. Blood supply 1.5 liters per minute, 2 sources, major 75% portal vein, the second source is hepatic artery. Venous drainage, 3 veins, right, middle and left. Middle and left usually joined together, the right one drains separately into the inferior vena cava. Then we came to the functional division of the liver into the right and the left lobes and how the segments are demarcated and what is the importance of knowing about them. Okay? Right. So physiology. The liver is the largest gland in the body and has multiple functions ranging from storage, metabolism, production of various factors and secretion. Where all is glycogen stored? 2 places where glycogen is stored. The liver and the muscles. And which of these 2 is the major store? The muscles. The liver has about 100 grams, the muscles have about 400 to 500 grams of glycogen stored in them. And why does the body store glycogen? Because in phases of fasting or starvation, this glycogen is broken down to release glucose. And why is that required? Because there are certain obligate glucose users in the body, especially the central nervous system. So, for providing glucose to the obligate glucose users like the central nervous system, glycogen is stored, and liver is one of the places where glycogen is stored. It is broken down in states of starving and fasting and release glucose for use of the central nervous system. When the body has exhausted the stores of glycogen, this process called gluconeogenesis takes over, wherein the substrate is non-glucose like amino acids, lactate, and they synthesize glucose for the purpose of utilization by the obligate glucose users. In a normal person, the liver helps to convert excess glucose into glycogen and store it. Once the capacity of glycogen is exceeded, it is converted to adipose tissue and it's stored as fat. The liver also synthesizes various plasma proteins, components of the complement system, albumin, etc. So various functions, we'll quickly go through them. Then there are immunological functions through the reticuloendothelial cells contained in the liver. What are they? What are the RE cells in the liver known as? Kupffer cells. So there are immunological functions which the liver subserves. Conjugation of bilirubin. The bilirubin which is released in the catabolism of heme is brought to the liver, where it is converted into a water soluble state by conjugation and is excreted out. Approximately 1 liter of bile is formed per day and is secreted. This aids in the absorption of fats. Certain drugs are metabolized in the liver. For example, paracetamol, rifampicin, isoniazid. These are metabolized in the liver before they are excreted from the body. These are briefly the functions that the liver performs in all of us. Now, we are more concerned about knowing how functional the liver is in a patient. So for that we have these two scores. The first is the Child-Turcotte-Pugh score. This often comes as a short note. Child Scoring System or CTP score. So this is based on 5 parameters: bilirubin, albumin, ascites, PT-INR and encephalopathy. I remember it as IPABA. You are free to devise your own mnemonic for it. But these are the 5 parameters which are considered when one calculates the CTP score. So, at the maximum points are 15 and the minimum are 5. So, a score of 5 to 6 points means that the liver is functioning very well, liver function is preserved. And the mortality of surgery, the mortality risk is around 10% in these patients. It gives an indirect idea about the functional reserve of the liver so that the chances of surgery can be prognosticated and the person can be told as to what is the mortality risk. Class B is when the score is from 7 to 9 points. The mortality risk rises to 30%, and when the score is more than 10 points, 10 or more, it is almost 70%. So naturally, in a child A patient, one can go ahead with surgery. In a child C patient, surgery is to be avoided because the mortality risk is extremely high. So this is the value of this scoring system. What is normal bilirubin? Less than 1. So this is 2 here. Bilirubin, albumin is more than 3 is normal. Ascites, there is no ascites. A PT-INR ratio of up to 1.5 is normal. So here if it is less than 1.7, it still scores at 1 and no encephalopathy. So these are the parameters, and that is how it goes. Even if you can't remember these values, at least remember this and remember the scoring. If it is 5 to 6, it is safe to operate. If it is 10 or more, surgery has an unacceptable amount of risk. The CTP is used to assess the hepatic reserve and predicting surgical risk in cirrhotic patients. Shall we move? Go ahead. The next one is the MELD, or the model for end-stage liver disease. This utilizes 3 parameters: bilirubin, INR and creatinine. So I won't go into the details of how it is calculated, that is slightly complicated, but it is these 3 parameters which are considered. It was originally devised as a tool to predict mortality after doing the TIPS procedure, transjugular intrahepatic portosystemic shunt. This is one of the procedures done for portal hypertension for temporary decompression. It is now used for deciding when to allocate a donor organ, the liver. Let us say a liver is available. Now the allocation to a potential recipient is based on the MELD score. Here again, a MELD score less than 10 can safely undergo surgery. Between 10 to 15, there is a slight risk. More than 15, elective surgery is not advisable. So these are the 2 scoring systems which give you some idea about the functional hepatic reserve and what is the state of the liver function. Okay. So the physiology part and the CTP and MELD score, comfortable. If it comes as a short note, can you write something on it? Liver has multiple functions. Even if you lose 75% of the liver, it will still regenerate and you will have the function. And an indirect idea or assessment is done with the help of these 2 scores, the CTP score and the MELD score. And these are also used to prognosticate the likelihood of mortality when a patient is undergoing elective liver surgery. Then we come on to imaging. Right. Some imaging modalities that you've heard of. Ultrasound, everyone knows about it. Most commonly available. It is cheap, relatively cheap. There is no exposure to radiation. Well tolerated by the patient. See what you see here. Can you see this lesion here? Compared to the rest of the hepatic parenchyma, this is hypoechoic. So most likely this is a cystic lesion. So the advantage of ultrasound is it's widely available, it is cheap, there is no exposure to radiation, well tolerated by the patient, takes about 15 minutes to do an ultrasound scan, and it is good for detection of focal lesions to decide whether the lesion is cystic or solid. For a preliminary assessment in trauma patients, ultrasound is done in the emergency department. So the initial assessment in a trauma patient, it's a very good modality. Biliary pathology. What biliary pathology? The most important one, stones. So stones are easily detected if they are present in the gallbladder or the CBD with the help of ultrasound. So a good, cheap and widely available modality for diagnosis, and that is why this is always the first investigation that a patient undergoes when there is a suspicion of liver or biliary pathology. But it has some limitations. Like we saw in the anatomy, the upper portion of the liver is under the rib cage. So that area becomes a little inaccessible to an ultrasound. So one is not able to define if a liver is placed in the posterior, if a lesion is placed in the posterior superior aspect of the liver. So the ultrasound is not able to define it well. It is operator dependent. How good or how reliable the ultrasound report is depends on how good the radiologist is. So if you can trust the radiologist, if the person is well trained, then you can take the report. But if the person is not well trained, then the report may vary between two operators. Not a very good imaging modality for obese persons, because the sound waves do not penetrate deep enough for adequate imaging. So not good for obese patients. They are also not good when the bowel is full of gas. The ultrasound waves get reflected back, as a result of which the imaging is suboptimal. And in these patients, we go on for other investigations like CT scan or MRI. Okay, so this is the advantage and the drawbacks of ultrasound. There are some newer advances which are coming in and other uses of the ultrasound. One is contrast enhanced ultrasound, in which micro bubbles are used, and this improves the imaging and is able to differentiate between benign and malignant lesions. Ultrasound is extremely useful when one is operating. Let us say one is operating for a liver tumor. You have removed the gross one which is visible to the naked eye, but there may be still some part which is hidden. So one does an ultrasound on the liver while in the operation theatre to see if the resection has been complete or there is something left behind, which is then also removed. That is intraoperative ultrasound. Then US elastography, also known as fibroscan. If you want to see this, you can walk over to the Department of Hepatology. They do it routinely. So fibroscan assesses the degree of fibrosis and fatty changes in the liver. Obesity is a modern day epidemic, and some of the fat also deposits in the liver. You have NAFLD, NASH, these conditions. So with the help of a fibroscan, one can find out what is the fatty infiltration in the liver, what is the fibrosis in the liver, and whether the person is likely to develop cirrhosis later on or not. So that is another use of the ultrasound. Next we come to CT, or computer tomography. Essentially a lot of X-rays which are then compiled together and analyzed with the help of a computer to construct an image. The CT scan could be conventional, which is an axial CT, or it could be helical, wherein the gantry rotates around the patient. Compared to ultrasound, the images here are better, they are more high resolution. Now ultrasound, the CT scan comes in a variety of options. You can have a basic 16 slice CT scan and going up to 256 slice or 500 slices per centimeter. So depending on how many slices the CT is able to take, the more is the resolution. Sometimes we have to do the CT scan after instilling contrast for better evaluation, especially where the lesion has a similar density as compared to normal hepatic parenchyma. So you can see here, that's a CT image. You see these hypo-intense shadows here. So these are metastatic deposits in the liver. Much better imaged than the ultrasound. A few slides back you saw the image of a cystic lesion. Compare that with this and you will find that this picture is much better. That is why CT is a better modality. It also helps us to differentiate between a tumor and a benign lesion. In a tumor, the blood supply is mainly from the hepatic artery. So immediately after injection of the contrast, the tumor becomes hyperintense, it lights up. While a normal hepatic parenchyma would become visible in the portal phase. This is a little complicated. If you want, you can skip this. The limitations of CT are, it is expensive, not so easily available. There is exposure to radiation because, like I said, these are multiple X-rays which are then combined to form an image. The contrast that we are using has side effects, especially on the kidney. It may be nephrotoxic. So one has to be careful whether one needs to use contrast or not. CT cholangiography is something new which is coming up. It is something similar to MRCP, where the CT is used to image the hepatocytes and the bile ducts. The next imaging modality is MRI. It utilizes magnetic fields and radio waves. What an MRI does is that first the magnetic field is administered, which aligns all the hydrogen atoms. Then radio waves are given, which agitate these hydrogen atoms. So there are two types of images, T1 and T2. The T1 images are when these alignment is happening because of the magnetic field, and T2 images are when the radio waves are being dissipated. So they have T1 and T2 images. This is how MR imaging is done. It can be a standard MRI, it could be a contrast enhanced MRI, or it could be an MRCP where the biliary tract is being studied. Compared to CT, an MR images soft tissues better. So that is why a soft tissue lesion is imaged better in an MRI. If required, contrast can be used, which is gadolinium based. What are the problems with MRI? I'm sure you must have had some exposure to MRI, some relative, some friend must have undergone an MRI. So what are the problems? More expensive, less easily available, but even more important than these two. Anyone who's undergone an MRI? The image acquisition takes a long time. You have to be in the gantry for nearly half an hour, 25 minutes. So people who are claustrophobic, who have metallic implants, they cannot undergo MRI. So see, why we have so many things is because each one has pros and cons. So that is why you need to know this and decide what is best for your patient. So MRI is very good for imaging soft tissues. It is very good for imaging the biliary tree when you do an MRCP, but image acquisition takes a long time. It is not easily available. It is expensive. It may not be possible to do it for patients who have metallic implants, pacemakers, etc. So you can't do an MRI in them. The next one is PET and PET-CT. So what does PET do? It gives you a functional imaging of the tissues. PET is based on the rationale that malignant cells or cells which are in inflammation, they take up glucose more avidly or more vigorously than normal tissues. And the isotope that we use is 18FDG, which is deoxyglucose labeled with fluorine. So a tissue which is more metabolically active, like it happens in cancer tissues or secondary deposits, that will take up this isotope preferentially compared to the rest of the tissues, and this would appear as a what is known as a hot spot. So why does one do a PET? Let us say a patient comes to you with the person has cancer of the breast, one of the common cancers in our country. Why would one like to do a PET? To decide whether the cancer is limited just to the breast or it has spread to other tissues across the body. So a whole body PET will tell you whether it is localized disease or it is metastatic disease. And this is what the logic behind doing a PET is, that cancer tissue takes up this isotope much more vigorously than normal tissue, and that is how it shows up. A PET is often combined with a CT scan, and you can see the difference here. This is a normal CT image wherein this deposit is not seen, but when you combine PET scan with CT scan, you are able to pick up even small deposits. Okay, so that is how modern day imaging helps you in deciding how extensive the disease is and what is the most optimal treatment for the patient. These are some others to complete the list: ERCP, invasive procedure, percutaneous PTCs, percutaneous transhepatic cholangiography, ERCPs, endoscopic retrograde cholangiopancreaticography, standard abbreviations, which is why I didn't write the full forms. And lastly, diagnostic laparoscopy, where not very often done these days, but more often done earlier, because imaging is much more efficient these days. Despite all this imaging, one may still miss out some secondary deposits. So that is why before subjecting a person to a full laparotomy, a laparoscopy can be done to decide whether there is any peritoneal disease or not. So this finishes the imaging part. So quickly, can we revise what we have just studied? What are the, firstly, enumerate the imaging modalities: ultrasound, CT, MRI and its modifications. Then you have PET CT. Okay, so the easiest, cheapest and widely available is ultrasound. It has pros, it has cons. It can pick up the gross lesions, but then if there is too much of bowel gas, if the patient is obese, it's not a very good modality. So we go on to a CT. CT can be a plain CT or a contrast enhanced CT, depending on what we are looking at. Then we have a PET, or before that we have MR, a combination of CT and MR. CT images the skeletal tissues better, the retroperitoneum better. MR images the soft tissues better. So often a combination of these two helps you arrive at a diagnosis. And then we have PET CT, which is once again to assess the extent of the disease. Let us say one has a carcinoma head of pancreas. CT and ultrasound seem to suggest that the disease is limited to the abdomen. But then you do a PET CT and you find a deposit in the brain. So that changes the stage of the disease and the treatment modality. So that is how one goes about imaging. Now to complete the lecture, the last part of the lecture was acute and chronic liver disease. This is more in the realm of medicine, so I'll quickly go through this in 3-4 slides. So acute liver disease, the main causes are infective. You have viral hepatitis A, B, C, D, and E. Then drug abuse or reaction to drugs, the most common being paracetamol. Tylenol or paracetamol overdose is, apart from alcohol, is one of the most common causes of acute liver failure. So paracetamol is not such a harmless drug after all. Okay. Paracetamol overdose, rifampicin, INH, halothane, these are some of the hepatotoxic drugs. Then shock and multi-organ dysfunction. Here, because the liver is getting poorly perfused, the blood supply to the liver is decreased, there is hepatocyte necrosis leading to liver failure. Others like mushroom poisoning, alcohol, acute fatty liver of pregnancy, these are some of the causes for acute. If severe, then the person would also have neurological signs in the form of flapping tremor, drowsiness, confusion, and encephalopathy, features of encephalopathy. The treatment is mainly supportive. Mild to moderate cases would recover with supportive treatment, but if the person goes on to develop acute liver failure, then one has to resort to a liver transplant in an emergency. The other spectrum of the disease is chronic liver disease. The causes here are a little different, the most common being alcohol abuse all over the world. Then chronicity of viral infection, that is chronic viral hepatitis. Then this one, which is rapidly increasing because of the modern day epidemic of obesity, that is non-alcoholic fatty liver disease, which may progress to non-alcoholic steatohepatitis. The deposit of fat in the liver leading to inflammatory changes, leading to fibrosis, which may ultimately progress to cirrhosis. So that is how this, and that is why the fibroscan is an investigation which is becoming very, very popular these days. Other causes like autoimmune, some toxins and herbal medications. So be careful when you take these local medicines available in the villages, which are supposed to be very good. Some of them may contain heavy metals and other alkaloids which could damage the liver. The features are jaundice, lethargy and weakness with muscle wasting. The circulation is hyperdynamic, the pulse pressure is wide, extremities are warm, other cutaneous manifestations like spider nevi, leukonychia and palmar erythema. Features of portal hypertension. Portal hypertension is a separate class in itself, so we'll discuss at that time. The normal pressure we saw in a previous slide is 3 to 5 millimeters of mercury in the portal venous system. When it is more than 10, it becomes portal hypertension, and that is when the collaterals open up. The most clinically relevant being the ones at the lower end of esophagus, the so-called esophagogastric varices, which may lead to bleeding. So that's skin bruising, gynecomastia, testicular atrophy. Chronic liver disease is supposed to be a hyperestrogenic state. Estrogen is normally metabolized in the liver, but if the liver is not functioning properly, there is hyperestrogenic state in the individual, as a result of which gynecomastia and testicular atrophy may appear. Okay? And lastly, of course, is hepatic encephalopathy. There are various grades of hepatic encephalopathy. It may range from mild confusion to coma. So we will not discuss the details. Just remember that these are some of the signs of chronic liver disease. The treatment would be as per the etiology. Early stages, discontinuation of the alcohol, weight loss, control of fat deposition in the liver may control the condition, but if it is beyond a certain stage, then one has to resort to liver transplantation. So I think I have covered the entire topic which was allotted to me today. So quickly, surgical anatomy, if it is a short note or part of a long question, can you answer? We start off with the embryology, the supporting ligaments, weight, blood supply, venous drainage, and I think if you write that much, that is good enough to answer the question. Liver imaging, once again, we have told enough modalities, starting from ultrasound right up to PET-CT. If you write 4 or 5 of them, that is enough to see you through. CTP score and MELD score, if you cannot remember all those values, at least remember the parameters and the score. Write that much and that should be enough to see you through. Clinical features of liver disease, MCQs, okay, so what's the weight of the liver? 1.5 kg. What's the blood supply per minute? 1.5 liters. Arises from the foregut. Okay. Segment 5 would be a part of the right lobe or the left lobe? Right lobe. So if you've been paying attention, you'll be able to answer that. Okay. There are which system supplies the majority of blood to the liver? Portal or hepatic artery? Portal, 75%. These are some of the MCQs which going forward for your NEET, PG entrances and all, you'll need to know. Any questions?